Next up for us is the immune system and also the lymphatic system, because those two kind of go hand in hand. We should probably do blood next, because then that would keep together the cardiovascular system being the heart, the blood vessels, and the blood. But because the immune system is kind of complex, and it's one of the more demanding tasks on the next exam, Module 2 exam, we're going to do that first to give you a little bit more time to study for that before the test. So let's start with first pointing out that these are really two separate systems, the lymphatic system and the immune system. Lymphatic system is sort of a second circulatory system to pick up fluid that leaks out of the primary circulatory system that carries blood. The second circulatory system is a good way for the immune system to travel around the body and find pathogens, so the two systems overlap. You might notice that I'm kind of going to read through the script as I go through this. There's a few reasons that I'm doing this. So I typed out a script because I've noticed that when I watch lynda.com videos, it's kind of nice to have the script there too, so that you can read along with what you're hearing. And I think it increases comprehension. So I apologize that this is going to sound like I'm reading things often. I do think it's probably a better way to get the information into your head in a couple ways, by both reading and hearing. Also, I do want to kind of increase reading comprehension skills, so when I do these videos, I think it's great that you can listen to them over and over, but I do think when you get to your higher end courses, when you need to use a textbook more and more often, you will want to be able to have those reading skills. So I want to increase those reading skills by having text on here too. Also, it's a sort of closed captioning as well. So let's draw out and see first that we've got the immune system and we've got the lymphatic system. We are going to start with the immune system first. But let's pull out a little bit more and see kind of our complexity here. So again, red is kind of foundational knowledge where you just need to remember some facts. And then as we move up from orange to green to purple, we're moving up Bloom's taxonomy. So you kind of see that there is a lot of foundational knowledge here in the immune system. Honestly, the immune system is a lot of facts, and those kind of facts kind of interact, but there's not a whole lot of higher order thinking here. I'm kind of always going to throw this at you or remind you of this, that Benjamin Bloom came up with something called Bloom's taxonomy, where basically he characterized the different levels of learning. So remembering is just kind of remembering facts. Doing some moderate or some mild kind of interaction with those facts is understanding. When you apply those facts, that's application. When you kind of figure out how facts affect other facts, or when you change a fact, that's called analysis. Evaluation is when the facts change, and you kind of want to see how everything changes with that. That's evaluation. So, for example, you would evaluate what is a consequence of CO2 levels rising. And then to me, creation is what are you going to do once those CO2 levels rise? What is the different plan? So you got to create a plan. I also want to keep at the forefront these mastery skills, or these big ideas in AP, which is you've got to have critical thinking. You've got to ask questions. You got to use digital literacy to curate information from the web and from other places to basically start to answer those questions. You got to avoid logical fallacies, so don't always go to the same sources. Don't always just go to things that agree with you. More brains are better than one, so socially collaborate. Try and see the big picture. Don't just memorize facts. And then use those first 5 steps to ask better questions so that you're back at the top again. I think an important thing in AP2 is to simplify complexity. So feedback is in positive feedback and negative feedback, hierarchical relationships. So how do atoms affect molecules, and molecules affect organelles, and organelles affect cells and tissues and organs and organ systems. So you want to look for those interrelationships at the different levels of hierarchy. Also, another big thing that's going to come up in this lecture too is organ system interrelationships. So how can one system cause another system to fail? One of the things you're going to find is the liver makes a really important component of the immune system called complement. So if the liver fails, the immune system will often fail. And then, of course, always back to form and function. So how does something look affect how it works? So how does anatomy relate to physiology? Then let's extend that into clinical testing, clinical care, pharmacology, and pathology. All right, a few intro slides. So this is just a nice picture of bacteria attacking cells, which are in blue, and a macrophage trying to get to the bacteria first. The lymphatic system and immune system are separate, but they overlap quite a bit. One of the difficulties in getting these systems is the systems are made of a lot of types of cells and a lot of relatively small organs. So for organs, you have the spleen, which is right here. You have the thymus, which is over here. You have lymph nodes, which accumulate in the armpits and the groin and the neck, the adenoids and the tonsils and the oral cavity and such. For cells, you have neutrophils, which fight bacteria, eosinophils, which fight parasites, lymphocytes over here, which fight viruses, macrophages to engulf pathogens and debris. So there's a lot of little parts of the immune system and lymphatic systems. What the immune system is doing is looking for pathogens, abnormal body cells, and toxins. I know most people will get the pathogens part, but do note that it can be more than just bacteria and viruses as well. There are other things out there like prions that are folded proteins in the wrong shape, and then they clog up the brain. And sort of related, microglia are immune cells that clean up proteins in the brain. So the main pathogens are bacteria and viruses, but there are other rare types of pathogens as well. Your immune system also prevents cancer. It's estimated that your body makes 1 cancer cell a day. What makes a cell cancerous is that it doesn't follow the rules of division. The major rules of cell division are don't divide if you're too young. Don't divide if there's not enough room. Don't divide if your DNA has been damaged. Cancer cells divide despite these rules, and they'll basically take up nutrients from surrounding cells. So a good way to look at cancer is that cancerous cells get so committed to division that they don't do their job, they steal energy, and they don't make themselves correctly. So the immune system finds cancer by finding cells that are so busy dividing that they don't take care of themselves, they don't look right. Your immune system also attacks foreign proteins. A lot of times this is not such a good thing when that protein is something like bee venom or poison ivy oil. Your immune system attacks something that isn't really going to hurt you. The reason I bring this up is that it'll be an important theme to understand that an immune attack isn't always great. You're killing cells, you're causing inflammation. There are diseases where the consequences of an immune attack are worse than the initial threat. The immune system has to keep in balance the collateral damage it will cause in mounting an attack versus the damage that will be caused by losing the attack. I like these pictures because the resonant word is perspective. I think the perspective in AP is why do I need or want to know this? And the answer is that it relates to disease. That could be a disease that you treat someone for if you're in allied health, or a disease that might happen to you or your family. I think disease is the motivating force in AP. Getting back to this theme of balancing the attack, the 3 failings of the immune system are immunodeficiencies, where the immune system loses the attack, autoimmunity, where the immune system attacks self, and then hypersensitivities are somewhere in between those two, where the attack may be right, but the consequences of the attack are worse than the initial threat. So, for example, anaphylaxis. In a little bit more detail then, immunodeficiencies are when the immune system stops mounting an attack. And examples of this are severe combined immunodeficiency or acquired immune deficiency syndrome. Autoimmune is when the system attacks itself, as in type 1 diabetes or rheumatoid arthritis. And then hypersensitivities will include things like allergies, anaphylaxis, lupus, and then also blood transfusion reactions. So let's start seeing the big picture and the right perspective. Seeing the right perspective is motivating, and that these are where you get your aha moments. We have a 2-sided concept map here. This side looks fairly complex. This is just the simple side, honestly. This is the lymphatic side. Things like what are the organs in the lymphatic system, so things like tonsils and thymus and spleen. We'll also talk about the structure of the lymph node, diffuse lymphatic tissue, and autoimmunity. You might also want to note 2 of the things that you can do for additional credit on the test is to memorize primary versus secondary, as well as types of immunity down here. My philosophy is I'm going to ask you to essentially reproduce the entire immune system, and then if you can go above and beyond by turning these into simple stories, then they're not that hard to memorize, in addition to what you already have to memorize. So the additional credit is to provide a carrot to see the story behind these types of immunity and memory. The other side of the chart then is the parts of the immune system. The first thing you might notice is that there are a lot of parts. Your task on the test is to reproduce this chart. The reason I do this is because, as we'll see, there really are a lot of parts, and if any one part fails, the whole system can fail, and you can die due to an infection. We'll have some specific examples later, but if we cross out one of these boxes, or just a couple of these boxes, your immune system can lose the entire attack. So I think since every part is important and failure of any one part can lead to death, I think it's fair to ask you to memorize the whole thing. I can show you examples that this is a very doable thing. I can show you previous year's tests, so please trust me that you will be able to draw all of this out if you're a motivated student. All right, so immune. We'll start with immune and then we'll come back to lymphatic. Already though, when you start drawing this all out on a big sheet of paper, you can see the overlap. While there are a lot of pieces to the immune system, a lot of the immune system resides in the lymphatic system. We'll go through each of these pieces next, but just appreciate now the complexity and the sheer number of parts of the immune system. There's a whole lot of parts. So maybe the first thing to note from this broad view is there are lines of defense. There's what's called a first line of defense, a second line of defense, and a third line of defense. And we'll go a little bit deeper into the first line of defense using cystic fibrosis as an example, and then we'll go into the third line of defense. So what would happen if you lost something called a TH cell? Or why do you only get the chickenpox once, but you get the flu or the cold multiple times? You might, honestly, just skip to this video on YouTube. This is one of the parts of the video. There's multiple parts, but rather than going through the lines of defense, you might just watch this video and draw it out. And we're certainly going to draw this out in class. I feel like I still need to kind of lecture the parts for the Prezi, but you might actually, if you only want to watch one part to get your lines of defense, you might just watch these videos on YouTube. Alright, so the first thing to do in organizing all these parts is to appreciate that there are multiple lines of defense. The basic principle is keep it out first. And then, well, it's in. I don't know what it is, but it doesn't belong in, so let's kill it. And then lastly, it's been here before. It hurt me. I'll remember it for next time. That's the third line of defense. So the first line of defense is essentially barriers. The second line of defense is often called the innate system because you're simply born with it. It is also called non-specific because it doesn't know the difference between pathogens. So again, it knows it's not right, but it doesn't know what it is exactly, and it's still going to try and kill it. The third line of defense is called adaptive or specific because it learns and remembers the threat to be able to stop a second assault. So this is why you only get the chickenpox once for the most part. There's always a few people that know somebody that got the chickenpox a couple of times, but for the most part, you're only going to get the chickenpox once because of the third line of defense. So here again, barriers. I like to think in metaphors or pictures. The Great Wall of China is like a barrier. Non-specific, it's going to attack all these various different pathogens, but it doesn't really know what the difference is between them. Whereas the yellow here is supposed to indicate the specific defense. So it knows what the pathogen is, and it remembers that pathogen. So it will attack harder if it sees that pathogen a second time. We're going to go through physical barriers first. So physical barriers are on our sheet here. We have epithelia, cilia, mucus, hair, gastric juice, antimicrobial proteins, and symbiotic bacteria. We'll go through each of those individually. Epithelia line all external surfaces. Technically, any surface that opens to the outside is an external surface. This can be skin or cells lining the digestive system, respiratory system, and reproductive system. Any external surface will have cells that are basically sealed with tight junctions, so there's a seal between the cells. Technically, the seal is caused by something called a desmosome. Essentially, a pathogen on the outside of a tight junction will have difficulty penetrating this barrier and getting between these cells. I think it's neat that even below the epithelia, usually it's not shown in this picture, but there's still a thick layer of dead tissue called a basement membrane. Dead is in, there's not a whole lot of living tissue in there, and there's not any blood flow in there. There's just basically protein matrix, and that's called the basement membrane. So even if a pathogen makes it through the cells, it still has to make it through the basement membrane before it could get to blood vessels where the pathogen could really spread. There's additional things on epithelia, like there's skin acidity that will make it hard for bacteria to grow. There are chemicals that are toxic to bacteria, and then saliva and lacrimal fluid actually have lysosome to kill things. Cilia are small hairs that will sweep debris toward the esophagus. So they will sweep things down from the nasal cavity and up through the airways of the respiratory system towards the esophagus. When pathogens are swept towards the esophagus, they'll end up in the stomach where they'll be killed by gastric juice. One of the things to consider if you smoke is that paralysis of cilia, as in smoking, will increase the risk of respiratory infections. Mucus lines many external surfaces, including the respiratory system, the digestive system, and the reproductive system. When pathogens are stuck in mucus, they can't spread quite as easily, so mucus is kind of a sticky trap. Also, often this mucus is pushed towards the digestive system where the gastric juice will kill any pathogens in it. Another interesting protective function of mucus is that it blocks the opening to the cervix in most days of the cycle except just prior to ovulation. So bacteria can't enter the uterus. Well, really neither can anything else other than that the path is cleared for sperm during the days of ovulation. Hair is seems like a weak one, but hair will protect against abrasion to prevent opening up the skin where pathogens can penetrate. So think about how your hair is pretty tough. It makes it harder to scrape your head. If you fall and scrape your knee, you're probably going to get a cut, but if you fall and bump your head on concrete, you often don't get a cut. And that's great because you have a lot of capillary beds underneath your scalp and you really don't want a cut there. Hair also alerts you to the insects that have landed on you, so this alert may allow you to get rid of the threat before the insect can bite you and expose you to things like malaria, Zika, West Nile virus, things like that. Gastric juice is the hydrochloric acid in your stomach, so the acid in your stomach is good at breaking down proteins, whether that's in the food you eat or the proteins that make up pathogens. So that will kill a lot of pathogens that are in your food. Antimicrobial proteins are found in the respiratory system. If you look, this is called a crystal structure, where it's kind of you shoot x-rays at a protein and try and figure out its structure. It sort of looks like there's a tunnel going down through there, like you're looking down a spiral staircase. They're also called defensins. Defensins can identify bacteria and then put holes in them, so those holes will kill the bacteria. Next is symbiotic bacteria. Symbiotic bacteria are the bacteria that are currently in you. They'll try to fight off invading bacteria simply to protect their own home. So, for example, there are strains of E. coli that are commonly found in the human gut. These E. coli will protect us from the E. coli in spoiled food. A further example is that after a person has taken antibiotics, the normal gut flora is often killed off, and the person may then get repopulated with C. difficile. That's going to be a problem. A treatment method then is to repopulate again the gut with E. coli via fecal transplants. That is just as it sounds, and you can look it up. There are some other barriers that I don't really go into in detail. Sneezes that clear the upper respiratory system, and coughs that clear the lower respiratory system. So sneezes clear the nasal passages, coughs clear the lungs. In fact, if someone is having difficulty coughing as an osteoporosis or being on a ventilator, the risk of infection increases. So in osteoporosis, you get kind of hunched over, it compresses your lungs. It's hard to take the deep breath necessary to cough, and so you can't cough out mucus and things like that. That's going to increase your risk of infection. Emesis is also a barrier, so throwing up, where we clear out our stomach of something that might have bacterial toxins in it. And then this is the continuation of that video again, first line of defense. I want to go into a small tangent that demonstrates how important the first line of defense is. In cystic fibrosis is the most common lethal genetic mutation amongst Caucasians. In cystic fibrosis, a transporter that moves chloride in and out of a cell is defective. In a normal lung, when this chloride is moved, sodium will follow, and when sodium chloride moves, water is going to follow. So this transporter allows water to be moved around and basically wash things out. Without the transporter, epithelia become covered in a thick mucus because the mucus can't be washed out or diluted with water. This mucus often overcomes the cilia, and so it basically blocks the respiratory system and it fills up the lungs with mucus. This mucus often blocks reproductive tubules, so people with CF are often infertile, and the tubules can also block the pancreas, so they become pancreatic insufficient. The lungs also fill with mucus, and if this mucus can't be moved to the esophagus, it becomes a pretty good home for bacteria. People with CF will generally acquire an infection with a bacteria that's pretty harmless to the rest of us. It's called P. aeruginosa. The cilia and mucus fail to move the bacteria out. It's also thought that the activity of the antimicrobial proteins are diminished in CF due to the inability to control sodium chloride concentration. So once the infection is set up, the immune system can no longer clear the infection, and over many years, the bacteria will destroy the lungs. Often it's said that once the infection is set up, then the timeline, or basically the countdown timer till death, is started. So the point is that without barriers, a person can get an infection from something that's pretty weak, a bacteria that's not going to affect any of the rest of us, and it will eventually lead to the person's death. What this indicates to me is that the immune system really does need all of its parts, and if you don't have all of your barriers, if you don't have mucus and you don't have cilia and you don't have antimicrobial proteins, you're going to end up with a bacterial infection that's going to kill you. Okay, so just trying to be a little bit more graphically clear that if you lose cilia, mucus, and antimicrobial proteins, you can get an infection that you can't clear and that will eventually kill you. Because weakening the immune system, even a little, will cause the immune system to lose, it suggests to me, at least, that our immune systems are in a pretty tight battle with the pathogens around us. If we weaken the immune system at all, the immune system might lose. I think this is a fairly important point for those going into healthcare to realize anything you do to affect the function of the immune system might weaken it and lead to the immune system losing. So if you don't wash your hands, you don't practice aseptic technique, you can really tip the balance in someone's immune system. In cystic fibrosis, we affected 3 of those boxes. In burns, you can affect just one of them, epithelia. So similarly, let's look at what happens to barriers with burns. So it's maybe even more striking in burns, you lose just one part of the immune system. The first threat to life after a burn is fluid loss. This is why we talked about the rule of nines when we covered the integumentary system, that if you have a burn, it's going to seep fluid. But after that, an infection is the next threat to life, as there's no epithelial barrier protecting the body. So now let's come back to second line of defense. The second line of defense is also called the non-specific defense or the innate defense because you're kind of born with it. It's made of phagocytes, natural killer cells, interferon, complement, inflammation, and fever. The first one, the main thing with phagocytes is that they'll find pathogens and debris and simply engulf them. Phagocytes have very prominent lysosomes to digest the debris they engulf. A primary phagocyte is a macrophage which is free to move around the body and find targets. Some organs like the liver and brain have their own phagocytes. You don't need to know the names, but in the brain we had microglia cells. In the liver they're called Kupffer cells. Also, smaller phagocytes that are in the blood are neutrophils and eosinophils. Neutrophils primarily attack bacteria, while eosinophils will attack parasites. The lime green is a reference to the movie Natural Born Killers, something natural killer cells always remind me of. In Natural Born Killers, there would always be some kind of green right before they would kill someone. Anyway, it's kind of an old horror film. NK cells will detect abnormal cells and kill them. A cell can be abnormal because it was poisoned with a toxin, it's infected with a pathogen, or it's so busy replicating itself, as in cancer, that it isn't making itself correctly. In each case, what the natural killer cell will do is rotate its Golgi apparatus towards the target. Remember that the Golgi apparatus is the protein shipping department of the cell. So you're rotating your protein shipping department towards the target. The NK cell will then release a protein called perforin, and perforins will put holes in the target cell. This is just an infographic on natural killer cells. Interferons are proteins released by cells infected with a virus to warn other nearby cells that virus is around. How viruses replicate is that they inject DNA or sometimes RNA into the host cell. The host cell doesn't really know where the RNA came from. It assumes that the RNA came from the nucleus of its own self. And so what it will do is it'll translate that RNA into protein. The viral protein then reassembles itself into new viruses. Interferon is thought to cause cells to temporarily turn off their ribosomes. If the ribosomes are not translating protein, then the infected cells are not producing the new viruses. In this figure, the green is the interferon, and the green cells are the ones that are infected. And you can see that they're releasing this protein to their neighboring cells to tell the neighboring cells, hey, there's virus around. Put your defenses up. While interferon is primarily used against viruses in the body, having the ability to turn off ribosomes pharmacologically also treats other things like hepatitis C, or it's even being used for cancer treatment these days. I guess I just said that, but additionally, interferon is also used to slow some cancers because by turning off ribosomes, the cancer cells can no longer make the proteins necessary for cell division. Interferon always reminds me of an anecdote when I was a kid. My dad would coach softball and we'd get TP'd now and again, but if my dad knew we were going to get TP'd, he would sit out in the bushes out in the front with a police siren, and he would let that police siren off once the softball team approached. The metaphor here is that if you knew virus was around, you could prevent it from infecting you, but you can't prevent it all the time. My dad could not stay up every night and protect our house from being TP'd, but if he knew it was there, he could prevent it. So if a cell knows virus is around, it can prevent infection by virus, but it can't maintain that defense all the time. Complement is probably the most complex system of the non-specific defenses. It's also probably the most important because not only can complement find bacteria on its own and kill it, the specific immune system and antibodies of the third line of defense use complement to kill as well. When finding a target, complement does three things. It will stimulate inflammation, which we'll cover soon. It will also tag the target pathogen, so a phagocyte can come along and say, hey, this cell has a target on it, and so I need to engulf it. Complement will also assemble many different C proteins shown in here as these C3b's and these C3a's. And what they'll do is they'll put a hole in the target, which is shown in this figure here. To review, then, complement can find a target on its own by recognizing the carbohydrate coat specific to a bacteria, or it can be alerted to attack something by antibodies. Once activated, complement will stimulate inflammation, flag the target for phagocytes to engulf, and begin to put holes in the target. Inflammation is kind of complex. First, the hallmarks of inflammation are swelling due to fluid in the area, redness due to dilation of capillaries in the area, heat due to increased activity, and pain due to swelling. So swelling, redness, heat, and pain. Essentially, inflammation is sending fluid towards the damaged area, and that damage can come from trauma, as in you twisted your ankle, or cells that are being lysed or killed by infection. This fluid moving towards the target will bring in healing materials like oxygen, platelets, and ATP. It'll bring in immune elements like complement and phagocytes and natural killer cells. It'll also provide a headwind against bacterial spreading. So if fluid is going towards the wound, it's hard for bacteria to spread when heading into that flow of fluid. So it'll prevent the spread of bacteria. Fever is an increase in temperature when the hypothalamus receives a signal called a pyrogen. Pyrogens can be pathogens, toxins, or antibodies that have found a target. When you ask a chemist what temperature is, they'll say it's how fast things move. When temperature increases in the body, all the processes speed up. So this speeds up the battle. This is why leaving a 101 fever alone will help you get better sooner. If a fever gets too high, though, it means the battle is being lost, and so you want to slow things down. Also, that high of a temperature can denature proteins, so you don't want too high of a fever. Fever also signals the liver and the spleen to take up things like iron and zinc, two metals needed by microorganisms to replicate. These molecules are secreted by leukocytes and macrophages and result in a fever. Those would be pyrogens. Just when we think we know everything, interferon can be found to fight cancer. You're a liar. Did you know that's not it? Interferon might also stimulate other immune elements like, nope, that's not it. It's even cooler. What it is it's found that, what it's found is, again, I kind of already mentioned this, that interferon is thought to also fight cancer. Just wanted to go back and review P53. It was something we did in AP1 real briefly. Is cancerous cells are dividing when they're too young, when there's not enough room, or they already have damage. P53 is a little protein that's over here. Its job is to basically shut down mitosis, which is shown down here by the G1 phase, the R to S phase, when there's DNA damage. So if you know somebody has a weak P53, they're more prone to cancer, but it's nice to know that we have this interferon out there that might slow down cell replication when cell replication is unchecked in cancer. So just trying to bring up that interferon might play a role in cancer treatment. If you could take stem cells and grow up a whole bunch of types of immune cells, which would you want to treat cancer? You'd want natural killer cells are the ones that are thought to fight cancer. These molecules are secreted by leukocytes and macrophages and result in a fever. Already did that one kind of a little bit different, I guess, pyrogens. Here are the videos. Again, I might just go straight to those videos if I just want to do lines of defense. Boy, already looking at this, we can see that the third line of defense is much more complex, but I suppose we are already aware of that because we saw it on the infographic over here. Let's start. So when we move to the third line of defense, there's some important themes to recognize. One, the third line of defense uses memory cells to remember a pathogen. This helps the immune system have a stronger response the second time it sees a particular pathogen. This is why most of us will only get the chickenpox once. The third line of defense can surround pathogens, but it really needs to use complement from the second line of defense. So the liver makes complement, so someone in liver failure might be immunocompromised. So what I'm trying to say there is the third line of defense uses antibodies, and antibodies have difficulty killing something on its own, but they can immobilize, neutralize, and then use complement to destroy that substance. Perhaps the most important theme is that the immune system needs to react precisely. If the immune system fails to respond, Perhaps the most important theme about the immune system is it needs to react kind of precisely. If the immune system fails to respond, the pathogen may win and cause death. But there are risks when the immune system overreacts. Inflammation can be damaging, and antibodies can begin to attack self. Also, the third line of defense, just looking at it, is clearly pretty complex. There are multiple cells. There's also a hierarchy where there's a small threat will be met with a smaller response than a larger threat. And we'll get to that. You kind of want to amp up your threat. If you have a small localized infection, like I'll show this in class, that I was cut by barbed wire while I was canoeing a long time ago. Well, if that infection was small and it just kind of stayed in that area, then we want a small response. If it spreads a little bit up to the lymph nodes, well, we want to be able to kind of take care of that. It's spread a little bit, but we don't want to go all out yet. But if enough is spread up to the lymph nodes to get deep into the lymph nodes, and it's gone well up into many lymph nodes, then we need to activate the immune system as hard as we can, and we need to make antibodies. But again, if you don't need to get to that step where you make antibodies, you don't want to get to that step that makes antibodies, because antibodies can attack the wrong things. Antibodies can cause inflammation. So there's two primary parts of the third line of defense. One part, T cells, will kill cells that are infected with a pathogen. This is called cell-mediated immunity. The principle is that it's better to kill a cell and make a new one rather than let a cell act as an incubator for the pathogen to multiply. A second part of the third line of defense identifies pathogens that have not yet made it into cells. Because this system uses antibodies to kill pathogens that are still in the body's fluids, this system is either called antibody-mediated or humoral, as in fluid-mediated. These two systems are pretty logical in that you will want to kill pathogens that have gotten into cells and kill pathogens that have not yet gotten into cells. The T cells in the cell-mediated system are created in bone marrow. These cells will then move and mature in the thymus. B cells are created in bone and stay there for maturation. An odd fact that demonstrates how naming in anatomy can be weird is that the B in B cells, you'd think it stands for bone, but it actually refers to an organ found in birds called the bursa. We're going to go ahead and pretend that it stands for bone, though. So T cells mature in thymus, B cells mature in bone marrow. Both are made in bone marrow, but T cells mature or move to and mature in the thymus, and B cells stay in the bone marrow. There's a lot of detail in this figure, but I think we can break it down fairly simply using the theme in Goldilocks. You want things to be just right. With T cells, you want them to be able to bind to pathogens, so positive selection simply means that we want T cells that will react to foreign pathogens. If they don't bind to test proteins, they're not going to bind to pathogens, so they're destroyed. Again, a theme, I'm going to say it over and over, in the immune system is you don't want too little of a reaction and you don't want too much of a reaction. So T cells are also tested for too much reaction. Too much reaction would be a T cell that binds to a protein normally found in the body, a self-protein. This is called negative selection. We also want to talk about what sort of target is the immune system looking for. The immune system doesn't want to waste time on things that are not alive, that are not replicating, that are not stealing energy, or that are not lethal. It's actually a bit of a mistake that the immune system responds to things like poison ivy and latex. Why waste that energy? So let's first get the technical details over with. The immune system targets antigens. Antigens are anything the immune system targets. It's a bit of a circular reasoning because the immune system attacks antigens. What are antigens? Things the immune system attacks. But do note the term antigen because it can be confused with antibodies. Antibodies target antigens. An antigen should be large, complex, and not self. So the antigen should be large and complex to make sure it's something that's trying to replicate and steal resources, unlike things like bee venom. The antigen should not be self, otherwise the immune system would destroy things that the body needs. A foreign molecule which can invoke the immune response is called an antigen. Another caveat before we get into the details of the third line of defense is the way the immune system tries to ensure that the target is large is to use antibodies with a Y shape. The target is only big enough if it activates both tips of the Y. Unfortunately, sometimes an antigen that's too small to be harmful, it's called a hapten, will bind to a carrier protein, which could be any kind of small protein. Together then, the antigen and the carrier protein can activate an antibody. An antigen that's too small on its own to activate an antibody but has found a carrier protein to elicit an antibody response is called a hapten. Haptens are why you can develop an allergy at any time, because many of us will not be allergic to poison ivy, but then one day the poison ivy oil finds a carrier molecule, binds to it, and together they cause an immune response. Essentially, haptens are why we can develop allergies at any time. In fact, as healthcare workers, you should probably avoid things like latex, which is a natural protein, to avoid developing an allergy, since latex is still used in certain healthcare applications. So essentially, you can be lucky and lucky and lucky, and then one day you have something in your body that's a hapten that binds to a carrier molecule, and now you have an immune response to it. So you can develop everything from hay fever and other allergies at any time in your life. Now that we've talked about some of the minor details that relate to the third line of defense, what an antigen is, what haptens are, where do T cells and B cells mature, let's get into the specific mechanisms of the third line of defense. Let's start by reiterating the point that there are two parts of the third line of defense. The cell-mediated system uses T cells and attacks cells that have already been infected. It's better to kill the cell, make another one, than to try to save the cell while it's acting like an incubator. So what I'm trying to show here is this cell is infected with a bacteria. Let's kill the cell. The humoral or antibody-mediated system uses B cells to try and find pathogens that have not yet made it into cells, and that's the humoral or antibody-mediated system. The cell-mediated system has three main types of cells. There's more if you look it up on Wikipedia, but the three main cells are TS or T suppressor, TC or T cytotoxic, and TH as a T helper. So let's do the easiest first. TS or T suppressor cells are there basically to calm the system down when there's no threat. Again, a key theme of the immune system is to not overreact. TS cells prevent immune overreaction when there's no threat. TC cells are also called T cytotoxic cells. Unfortunately, they're also called CD8 cells. Sometimes in science, a group is working on a type of cell and they find it and they call it a T cytotoxic cell. Then another group is working on another group of cells and they're calling them CD8 cells. And lo and behold, they're the same cells. So that's how cells can get two different names. TC cells will kill cells that are infected. TH or T helper cells are also called CD4 cells. TH or T helper cells are also called CD4 cells, and what they do is they alert the immune system that a greater response is needed. Again, we don't want our immune system to overreact, but we also don't want it to underreact. TH cells help us to signal that the system needs to react more. So in the example I cited before, where I have a cut on my wrist from barbed wire, if that infection stays local, then just TC cells will kill it. But once it starts to spread to the lymph node and gets deeper in the body, we're going to activate TH cells to basically tell the immune system that this infection is spreading, we got a bigger infection, and we need to mount a bigger response. TC and TH cells find infected cells by binding to a protein called major histocompatibility complex, or MHC. Where it comes from is histo means blood, compatibility means blood type compatibility. So this was discovered when they were finding the problems with donating certain types of blood or blood transfusion errors. When a cell is infected, it will digest some of the pathogen. So if this is the infected cell, it will take some of the pathogen that's infecting it and it will put it on the cell surface in this thing called MHC. So MHC will deliver a piece of the pathogen to the cell membrane and present it to TC or TH cells to alert these TC cells or TH cells that the cell has been infected. So TC cells are looking for cells that are displaying an MHC for a specific target. And by specific target, we mean the MHC isn't looking for not a bunch of different pathogens. It's looking for one specific pathogen. There's two types of MHC. MHC1 will stimulate TC cells. MHC1 is found in all cells that have a nucleus. So a cell has to have a nucleus to make the MHC. So blood cells are kind of sort of out of luck, but most cells will be able to report to a TC cell that they are infected. MHC2 is found on a special subset of cells called antigen-presenting cells, or APCs. APCs tend to be deeper in the body, mainly in lymph nodes. To begin understanding the hierarchy of how the immune system attacks, note that any cell can activate a TC cell. However, a cell needs to be deeper in the body to activate TH cells. So a small infection will activate TC cells, but a bigger infection has to penetrate deeper in the body before TH cells are activated. The way I used to think about it is I grew up in Iowa and my grandfather grew up in Boone. And in Boone, Iowa, there's a really big, longest two-track railroad bridge in the world. It's called the Kate Shelley Bridge. And when my grandpa would take me there, he would point out to me that there were sentry posts or there were guard posts so that during World War II, the bridge wouldn't be bombed. And I just remember thinking that if this bridge ever in the middle of Iowa gets bombed, then we're in a lot of trouble with World War II. So like TC cells would be out on the surface where you expect to fight. TH cells are basically those sentry posts in a bridge in the middle of Iowa. If those are infected or if those are attacked, you're in a lot of trouble. So TH cells are basically designed to say, hey, we're in a lot of trouble. We need to get our immune system going a lot stronger to fight off this attack. I think this figure is a little bit deceptive because it's trying to show both MHC1 and MHC2 in the same cell, and that's not my understanding. Those would be in separate types of cells. Maybe ignore that part and just visualize the process where a cell is infected with a pathogen. So essentially, these are the pathogen, these little yellow guys. A piece of the pathogen is taken and it's put into the MHC. Then the MHC moves out to the cell surface where it presents it for a T cell to find it. Once a T cell is activated, it's going to begin its attack. For TC cells, that's going to be different than TH cells, and we'll go into that. TC cells are for smaller attacks, while TH cells are activated with deeper infections. This figure is a little bit redundant, but I wanted to emphasize that MHC1 alerts TC cells, and those are on any cell that has a nucleus. So MHC1 is on any cell that has a nucleus. MHC2 down here are basically in antigen-presenting cells. This slide describes what happens when TC cells and TH cells find an infected cell that is presenting them with an MHC that they're looking for. So again, TC cells are not looking for a bunch of different types of MHC. They're looking for a very specific MHC that's holding a very specific part of a pathogen. When TC cells find a cell infected with a pathogen that the TC cell is looking for, it will first make memory cells. Memory cells are backup cells. They will not enter the fight right away, but then they'll be ready when the next time the pathogen is present. The TC cells will then also create more active cells, and those more active cells will target infected cells in 3 ways. They'll release lymphotoxin, which disrupts the metabolism of the target cell, so it can't make ATP. It's going to stimulate programmed cell death, which is also called apoptosis. So all your cells in the body have genes that, when expressed, will cause the cell to die. Those are kind of like a self-destruct button. So TC cells will stimulate self-destruction in the infected cells. TC cells will also release perforins, just like those used by natural killer cells, to put holes in the target. When the TH cell finds an APC cell presenting an MHC2 with a pathogen they are matched with, the TH cells will also make memory. I failed to put it on the slide, but TH cells also make memory. Recall the APC cells tend to be in the lymph nodes, and so they're deeper in the body. Man, I'm hitting that point multiple times. So when an APC cell is infected, that infection is spread deep to the lymph nodes. Keep it in mind, we haven't talked about the lymph nodes, but I did mention it briefly. The lymph nodes tend to be in the armpits, and they tend to be in the groin and the neck. So if I have a cut out on the wrist, and that pathogen has made it to my armpit, where the lymph node is, and where the APC cell is, I've got a big infection. So TH cells finding an infected APC cell should signal the immune system to increase its attack. When TH cells are activated, they release these things called interleukins, which is a type of cytokine. And what it's going to do is signal the TC cell to work harder. TH cells will also come together with a cell called a B lymphocyte, which we'll talk about shortly, to make antibodies. Each of the cells in the third line of defense, TC, TH, and B cells, will make memory when they find their target. Memory cells, again, won't fight right away. They're kind of like the Army Reserves. They'll be there as a backup the next time that there's a threat. So let's switch over to the B lymphocytes and the humoral or antibody-mediated system. When antibodies are used, there's a risk of inflammation and incorrect targeting. There's an example, I don't know the citation anymore, but there was an example I read about once where they did a clinical trial where they injected antibodies to essentially attack the plaques that are present in Alzheimer's patients. The resulting inflammation led to a lot of swelling, and I believe all of the participants died from the inflammation. They had swelling in their brain, and swelling in your brain is not a good place to have swelling because it's a confined space. Another thing we'll kind of come back to is once an antibody is activated, it might bind to other proteins accidentally in the body. This will lead to the immune system attacking self. This is one of the theories of how you develop autoimmune diseases. You make antibodies against a certain pathogen, but that antibody also starts to accidentally recognize a self protein and starts to attack it as well. B lymphocytes carry their own antibodies that are attached to the outside of the cell. These technically are what are called IgD antibodies. B lymphocytes tend to reside, I don't really have a picture here, but when fluid comes into a lymph node, B lymphocytes tend to hang out right where the fluid comes into the lymph node. So you can imagine back to my metaphor where I've cut my wrist and the pathogen starts to spread. If just a few of the pathogens travel into the lymphatic system, the B lymphocyte is going to catch it with those IgD antibodies. And this process is called sensitization. So if only a small amount of the pathogen makes it to the lymph node, the B lymphocyte will immobilize it just using the antibodies on the outside of its surface. If, however, enough pathogen spreads to the lymph node to overwhelm the B lymphocytes, it's going to get past that entry level into the lymph node. So the B lymphocytes are basically blocking right at the entry to the lymph node. And if they're overcome by pathogens, then the pathogens will get deeper into the lymph node. TH cells hang out deeper into the lymph nodes, so now you know you've got an infection that's made it to the lymph node, made it past the B lymphocytes, and is well into the lymph node. And here's the time when you need to activate the T helper cells. So then what will happen also is the TH cells that have found the pathogen will actually link up. It's shown in this figure that the B cell and the T helper cell will come together, and what's going to happen is now this is an activated B cell. An activated B cell will transform itself into something called a plasma cell, and it will start making antibodies. So it's very important that the TH comes together with a B cell if you want to make antibodies. So sensitization is the process of a B cell first finding a target. If a TH cell is also activated, the TH cell and the B cell will come together to activate the B cell. And then the B cell turns into something called a plasma cell, and the plasma cell starts kicking out antibodies. If AIDS attacks TH cells, choose the best answer. Losing TH cells is a pretty bad thing, so I would say B. Oh, no, wait. No, the thymus would be far worse because the thymus would have not only TH and TC cells. So TH cells, losing TH cells because of HIV AIDS is pretty bad, but having no thymus as a young person would be much worse because you do not have TH or TC cells. So the answer here would be D. All right, so antibodies, getting back to antibodies. Antibodies are also known as immunoglobulins, as in globs of proteins that have an immune function. And that term is the basis for naming the types of antibodies. So you'll see that the 5 types of antibodies are called IgM, IgA, IgD, IgG, IgE. I like to organize them so they spell MAD, so they're easier to remember. IgM are the first antibodies made. So when you first see a threat, IgM antibodies are huge antibodies, and they're the first ones made. IgA antibodies tend to be specialized in protecting epithelia. IgD, as we mentioned before, are the ones that are found on B lymphocytes. IgG antibodies are older antibodies. And then IgE antibodies stimulate inflammation. So here's a little bit more detail, but I think what we just covered is probably simple enough. But let's hit a little bit more detail. So an increase in IgM would indicate the presence of a new pathogen. An increase in IgA might indicate that there's an epithelial-based infection. An increase in IgD could indicate overproduction of B lymphocytes and thus leukemia. So you can measure the concentration of these antibodies. It's called a titer. And by measuring that concentration, that can help diagnose what could be going wrong. So IgG antibodies can be measured to determine if someone has been exposed to a particular type of bacteria. So that's what they're doing when they're testing you for tuberculosis. They're exposing you to a tiny amount of tuberculosis. And if you have IgG antibodies against tuberculosis, you'll attack that little exposure and cause inflammation. You get swelling at the test site. And then they know that you have IgG antibodies against tuberculosis inside of you. And then IgE can indicate an inflammatory response. Nice figure. Goes through all the different ways that antibodies can attack. So once antibodies find a target, they can't kill it directly, but they do have several strategies to slow the spread. Neutralization means to surround the pathogen. A pathogen can't get into a cell without binding to a cell receptor. They don't just bore their way into cells. By surrounding the pathogen, it can't bind to a cell receptor, get into the cell, and replicate. Agglutination means to clump large objects. So if objects are clumped up, they can't move around as well. Think about a 3-legged race, or sometimes you'll see when a group of small kids in a preschool are walking towards the park, whatever preschool directors will have the kids hold onto a rope. And if all the kids hold onto a rope, they really can't move that fast. And that's the same kind of thing. If a bunch of pathogens are clumped together, they can't move very fast. I think about precipitation as meaning to clump small things. So if objects are really small, they're like floating in solution, they're dissolved in solution, they can move around pretty easily. But clumping them together makes them fall out of solution, kind of like a cloud can move around a lot. But if that vapor precipitates into a rain, it's not moving around as much anymore. So once out of solution, then the pathogen's mobility is reduced. Lastly, antibodies over here can activate complement. Now this was up in the second line of defense, so this should be review at this point. But it can flag the cells for phagocytosis, so it can flag the pathogen for phagocytes, stimulate inflammation. Oh, and it can also assemble C proteins to cause cell lysis. So complement causing phagocytes stimulates inflammation and puts holes in the target. Let's take a look at how those memory cells that we mentioned actually work to create a better response the second time a pathogen infects the body. So the first time a pathogen infects the body, this is called the primary response. The second and subsequent times a pathogen enters the body is called a secondary response. The secondary response is much faster due to the presence of the memory TCTH and B cells. There are three main differences between the primary response and the secondary response: the time till antibodies are made, the number of antibodies made, and the duration that those antibodies made. And all three of those can be seen in this graph. You can, when you do this as extra credit, turn this into a table, or you can use this graph. In the graph, the primary response is the initial exposure. The secondary response is the secondary exposure. Notice first how long it takes to make antibodies. So it takes 3 to 6 days to get antibodies made in the primary response. Notice how much faster antibodies are made the second time around, and basically you'll get antibodies upregulated in 2 to 3 days. Also note the amount of antibodies. So there's no real numbers on here, so I'll just tell you that there's about 1,000 times as many antibodies made the second time you see a pathogen. The other thing to note is notice that in the primary response, we get a peak and we immediately start to fall. In the secondary response, we get a peak and we start to fall, but we do still sustain our levels much higher than we had them in the primary response. And so our antibodies are made and sustained much longer in the secondary response. So again, primary response begins in 3 to 6 days. Antibody levels are 1,000 times less than the secondary response, and peak levels decline after about 10 days. In the secondary response, antibodies are being made in 2 to 3 days. There's 1,000 times as many antibodies made. And while the antibody levels will fall off after 10 days, there's still an increased level of production compared to after the primary response. So there's a lot more here than there was here. There are different types of immunity, and this is another thing that's worth extra credit on the test. So first of all, innate immunity is essentially genetic luck. If a person lacks the cell receptor a pathogen needs to infect, the person will be immune to that pathogen. It's thought that those who survived the bubonic plague did so because they lacked the receptor the pathogen needed to infect cells. Since the same receptor is used by the HIV virus, descendants of the survivors of the bubonic plague appear to be immune to HIV infection. But this also makes the difference between why some viruses can be passed through airborne passageways or why some have to get into the body's fluids. So, for example, HIV needs to attack a TH cell. Well, that's not really in the respiratory system, so you can't breathe in HIV and be infected because the cells in the respiratory system don't have the receptor necessary for HIV infection. Whereas flu and cold and things like that, there are receptors in the cells of the respiratory system that those viruses can attack and get into cells. So this presence of receptors also separates why some viruses can infect you in one way or another. Now we're going to come out here, and it's a little bit confusing how they've done this, but let's look first at passive versus active, and then we'll come back and talk about natural versus artificial. So first of all, passive immunity involves giving antibodies directly. You're going to inject the person with antibodies. If the antibodies are given through a natural pathway, so like breast milk or the placenta, this is called natural passive immunity. If the antibodies are given in an injection, as in like snake venom, or part of the tetanus shot is antibodies directly, and that's why when people donate plasma, that's one of the things they're going for, is they're going for the antibodies that you can give to somebody that's been exposed to tetanus. Then this is considered artificial passive immunity. As opposed to giving the person antibodies directly, you can teach the body to make antibodies, and this would be considered active immunity. If that active immunity is natural, like you've been exposed, or back in my day, my cousins got chickenpox. My mom had me go visit the cousins so that I would get chickenpox too. Chickenpox parties were really a thing back in the day. So then you'd expose your kid to chickenpox, get it over with, and then they wouldn't have to deal with chickenpox as an adult. So this is called natural active immunity. Natural active, you're infected. If the body's taught how to make antibodies via an immunization, then that's considered artificial active immunity. So artificial active immunity. That's one of those things where if you can just break it down into, well, I want to teach my body to make antibodies, or I want to give my body antibodies. And then these are the YouTube videos as well. Then it's pretty easy to break that down, the different types of immunity. All right, that's third line of defense. So let's look at a specific mini case study. Patient reports with recurrent nasopharyngeal, bronchial, ear, and urinary tract infections. He reports that this has a familial history with multiple ear infections in both his father and his children. So note the similarities between where these recurrent infections are taking place. These are epithelial surfaces. IgA protects epithelia. So a good diagnosis would be deficiency of IgA. You can also have overactive IgA. One of the theories of acne is that you have overreactive IgA and you're attacking bacteria that are normal and harmless in the skin. So what happens then is you stimulate inflammation, so you get redness. You bring in phagocytes to try and kill those bacteria. Some of them die in the process and make pus, and so then you get whiteheads. So acne might be overreactive IgA. Kind of a funny one, or at least it's funny to me, but probably not funny to anyone else. But if the liver makes complement, then liver disease would be a really, really bad thing. Because without complement, you don't have the ability to have the second line of defense, and also it limits the third line of defense because complement is used by antibodies to kill things. It's usually pretty well understood that most people will only get the chickenpox once, but the question then arises as to why we continually get influenza in the cold. Or why can't we make immunizations? Or why are we having such trouble making immunizations against things like cold, flu, and HIV? The answer is that looking at this figure, these viruses mutate often, and so they always appear to the immune system as a primary response. So you will only get a particular strain of the flu once, but there are many, many strains of flu. It's mutating often. HIV attacks the T helper cell, and if you were a virus, that'd be a pretty good cell to attack to prevent your own demise, because without the T helper cell, you're not activating the TC cell, and you're also not activating the B lymphocyte to make antibodies. I think I've made this point already that the liver is pretty important because it makes complement, which is important in the second line of defense, but it also, complement is what antibodies use to actually kill things. The liver does a whole lot of things. It makes clotting factors, it stores vitamins, it detoxifies, it helps break down fat with bile, and it makes complement. It does some other things in there that are not right on the top of my head, or that I didn't have on the top of my head when I made my script. So this is why, though, liver does a lot of things. And so if your liver fails, you can be dead in 24 hours. It's just kind of an interesting figure that shows the overlap between the different parts of the immune system. And again, I look at that like, boy, it's a cobbled together mess. But if you take out one of those things, so for example, if you took out neutrophils or if you took out natural killer cells, there's a huge gap in the immune system at that point. So you really do need all this overlap. Active artificially acquired immunity is a result of. So active means you're telling the body to make antibodies. Artificial, that would be an immunization or vaccination. So I like D, vaccination. Which of the following is the hallmark of the humoral immune response? So that's the antibody mediated. So that's definitely antibodies. So C, binding of antibody to the antigen is humoral. All right, that's third line of defense. Mastery thinking. Well, one of the questions on the test is going to be, please describe what breakdowns in homeostasis such as burns and cystic fibrosis tell us about the importance of barriers in immune defense. So what I'd like to see in an answer there is that burns takes out one barrier. Cystic fibrosis takes out 3 barriers. And this can lead to death by a relatively simple bacteria, at least in the case of cystic fibrosis. Or in the case of burns, you could die of bacteria that are not going to harm anyone else. So essentially, you could die of a bacteria that does nothing to anyone else, and it's going to weaken you if you've just lost a couple of barriers. What that tells me is that your immune system is in a very tight battle, a very tight race with the pathogens around us. And if you weaken the immune system at all, the pathogens can win. I think that's really important for people that are in allied health to realize, because when you put hands on people, you could be altering that balance in any kind of slight way. If you don't wash your hands, if you don't make sure that they wash their hands, if you don't make sure that you have aseptic technique, you could be altering the balance in such a way that now the immune system is behind and the patient will lose. We got some immune wrap-ups, so some little things that we have to talk about that are still related to the immune system, but they're not as in-depth as the lines of defense. So things like transplants, immunodeficiencies, hypersensitivities, and I guess I have bird flu on there from before, but we won't really cover bird flu. So first of all, transplants. Hopefully you're getting sick of me saying that the immune system has a lot of parts and they're in a tight race with pathogens. And if you lose one of those tools of the immune system, you are much more susceptible to infection. With that in mind, here's a good time to talk about transplants. Let's first talk about those organ transplant types before we talk about immunosuppressive drugs. So the 4 main types of grafts or transplants are autografts, isografts, allografts, and xenografts. An autograft, I kind of spelled that wrong, is when you donate to yourself. So you move something from one place in the body to another. An example is sometimes ligaments. Like if you tear your ACL, they'll take from the Achilles to replace one thing with another. Or a coronary artery bypass graft. So a bypass heart surgery would also be another example. An isograft is a donation from one identical twin to another. Most of us don't have that option. When we think of transplants, most often we are thinking about allografts, which is from one individual to another. Xenografts are from one species to another. An example of a xenograft is the use of a pig heart valve or even a cow heart valve to replace a human heart valve. There's been a lot of work going into generating tissue in other species because then you can genetically manipulate them so they don't have antigens that will activate the human immune system. So the drugs given to prevent rejection of transplant are immunosuppressive drugs. The idea with giving immunosuppressive drugs is you got to give just enough to prevent organ rejection without giving so much that the immune system is weakened more than it has to be. You should also look into these drugs. It's really amazing how these drugs, we don't really know how they work. We just know that it has an overall weakening effect on the immune system. Decreases inflammation, decreases TC activity, decreases TH activity. It's really not understood how these can have such multiple effects on multiple parts of the immune system. Immune deficiencies. So we mentioned in the introduction that there are three main ways the immune system fails. Hopefully you can repeat them without me even saying them yet. But you fail to eliminate the pathogen. You attack self fully with antibodies. And why I mean fully is because hypersensitivities are kind of an attack, but you're not fully attacking something. And then hypersensitivities are be a little too sensitive and suffer the consequences of an unnecessary attack. Let's come back now to immunodeficiencies. So first, in severe combined immunodeficiency, there's a marked decrease in the number of B and T cells. So the third line of defense is pretty severely weakened. SCID is congenital, which means it basically has a genetic basis. I asked this question, and you hopefully already know the answer because I've said it multiple times, I realize now. But if you were a virus and you wanted to ensure your survival by weakening the immune system, what cell would you attack? Immunodeficiencies can also develop over time as opposed to congenital or genetic deficiencies, which would be present at birth. So the two main examples are Hodgkin's disease and acquired immune deficiency syndrome, or AIDS. What happens in Hodgkin's disease is you've got cancer in the lymph nodes, and so the lymph nodes fill up with cancerous cells. These cancerous cells will alter the normal function where B and TH cells come together to make antibodies, as well as disrupting the function of macrophages. So in addition to its attack on TH cells, HIV is also a retrovirus, which makes it particularly evil because this means it's going to insert its DNA into the host. And so while you can give the triple cocktail and you can really knock down replication to the point where it's not really causing symptoms, there is some new research where they are trying to clip that DNA back out of the host DNA. So there is hope. Autoimmune. Redundancy is good. So again, a theme of the immune system is that overreacting to a threat may also have consequences. So in autoimmune diseases, the immune system attacks self-antigens, stuff that you want, stuff that you need. At the heart of an autoimmune disease is the loss of the ability to detect self from non-self. The immune system attacks self. In MS, or multiple sclerosis, the immune system attacks the myelinating cells in the brain called oligodendrocytes. And so what happens then is you might get short circuits of nervous signals, so it might affect motor function. For more examples, so up here, this is rheumatoid arthritis. So in rheumatoid arthritis, the immune system attacks joints, and then the joints continue their attempts at regrowth, and that causes malformation of the joints. In type 1 diabetes, this one's not in the figures, but the immune system attacks cells that make insulin. In myasthenia gravis here, the immune system attacks the receptor between the motor neuron and the muscle. It's called the acetylcholine receptor. And so muscles have become weak. In fact, the weakest muscles in the body, you might guess from this figure, are the eyelids. And so when the eyelids start to droop, that might be a symptom of myasthenia gravis. In Graves' disease down here, the immune system attacks the thyroid. So inflammation often develops behind the eyes, and it pushes the eyes outward. The causes of autoimmunity are not really well known. Clearly, there's an error in negative selection because the T cells and B cells that might recognize self are supposed to be eliminated. It's possible that there's been genetic mutations that cause a protein to change its shape, and thus it's now recognized as foreign. Or in the case of ion channels, it's thought like in myasthenia gravis, maybe the immune system recognizes the closed channel as self, but when the channel opens, it changes its conformation, and that is not recognized as self anymore. A hapten can bind to a protein as well and change its shape. So a hapten can bind to a self protein, and then the immune system starts attacking that self protein. One last possibility is that a new antibody is created. So a new antibody is created and it's produced in high quantities and it's used to attack a pathogen, but it also mistakenly attaches to a self protein. So here again is why making antibodies is somewhat risky. If a pathogen can be defeated with just TC cells or that BC cell, well, it finds it with its IgD, it's called sensitization. That's better than producing antibodies if you can help it, because antibodies sometimes will react to self and cause autoimmune diseases. I have a minor autoimmune disease. I have something called vitiligo, where your immune system starts to attack your melanocytes. Having Caucasian skin, it's not really very noticeable, but if you have more pigmented skin, it's much more noticeable. Michael Jackson was thought to have vitiligo, and then he took a drug to basically kill all his melanocytes off. And so then that's why he turned pale. Or Sammy Sosa also has vitiligo. One of the problems with that is now it's been shown that my immune system is prone to attacking self, and so I need to be careful and watchful for things like lupus or other autoimmune diseases. Hypersensitivities, you can think about them as minor autoimmune diseases, or you can think about it in terms of that the immune system is attacking appropriately, but the immune response has created side effects that are damaging in and of themselves. There's 4 types of hypersensitivities, and they're divided up by their time course and whether antibodies or T cells are the problem. So, for example, anaphylaxis can be fatal in minutes. That's got a really fast time course, but allergies are much more longer. So, in general, type 1 hypersensitivities are related to an overactive allergy, specifically things like anaphylaxis or shellfish or bee stings or things like that, allergies. Type 2 are related to blood transfusion errors. Type 3 are kind of a general low-level autoimmunity seen in things like lupus. Type 4 are hypersensitivities related to the skin, so allergies like poison ivy. Type 1, in anaphylactic shock, in the first exposure, you don't get a huge response, but you make a whole bunch of IgE antibodies. On subsequent exposures, those IgE antibodies are way too overstimulated and create a huge inflammatory response. Think about it this way too, it's a little bit scary, is I was stung by a bee when I was like 5 years old, and I was actually stung by a bee because my great-grandfather actually kept bees. But then for the next 44 years of my life, I was never stung by a bee again, so I could have gone into anaphylaxis with a second bee sting. We just don't know. Most of us don't know. Even though we're very scared of bees, most of us are not stung that often. In fact, many of us are stung once and never a second time. But last year, I stepped on a bee accidentally and was stung, and I didn't go into anaphylaxis, so I think I'm okay. An overblown inflammatory response kind of got away from that. But what we're talking about with anaphylaxis is too much inflammation, is too much of an inflammatory response. And what that's going to do is cause constriction of the bronchioles. It's going to be hard to breathe. It's going to have blood vessels dilate. They're going to lose fluid, and that's going to decrease blood pressure. The significant loss in blood pressure is also going to decrease preload on the heart, if you remember that from cardiac output. And that's going to result in shock from both the decreased cardiac output and the decreased fluid volume. So you're not pumping enough blood. The treatment is epinephrine or adrenaline, as this will cause the sympathetic nervous system to constrict blood vessels in the skin and digestive system to get blood back into the main system, as well as stimulate heart rate and heart contractility. So that's why you carry EpiPens. In type 2 hypersensitivities, there's been a blood transfusion error. I think I'm going to jump to the next slide, even though I typed this all out. Essentially, if we have a vial of blood from a type A person, and we took this A blood and we put it into someone with B or O, this B or O person is going to have antibodies against A blood. It turns out that if you have A blood, even if you've never had B blood in you, you're still going to have anti-B antibodies because those antigens are also in our food. So if you took A blood, put it into someone with B or O blood, they're going to have anti-A antibodies, and those anti-A antibodies are going to cause clumping of this blood. A lesser problem is if you took this plasma from this type A person, there are anti-B antibodies in this plasma. So if you give this plasma to someone with B-type blood, those antibodies, not to the significant degree of what's going to happen down here, but those antibodies can clump some of the B blood. This is why usually you don't give plasma to somebody, you just give packed red blood cells. Type 3 hypersensitivities can be thought of as a lower level and less specific autoimmunity. So in autoimmunity, the target is fairly specific, but in type 3 hypersensitivities, there are many targets that are attacked at a relatively minor but constant level. So like myasthenia gravis, the target is the acetylcholine receptor. The best example of type 3 hypersensitivities is lupus, where the body generally attacks things like, it could be the skin, could be the respiratory tract, could be a lot of things, could be the kidneys. So it can cause nephritis or the digestive system. So it's kind of a low-level general attack. The skin can be attacked, and so then people with lupus will turn pink from the inflammation. Type 4 sensitivities, I think I missed one here, but we'll just do it here. Type 4 sensitivities are things like the immune system is attacking things that it shouldn't be attacking, like the oil in poison ivy. I recall as a kid, and it's important for everyone to realize this, is not everyone is allergic to poison ivy. Like I couldn't identify poison ivy until I was 30 years old, but now I can identify it because it really, really causes a response in me. But up until I was like 18 years old, if like my dad needed some weeds cleaned out of a fence or something like that, he would send me in there because I would never get the poison ivy and he would get it so bad. But I developed it at 18 and it gets worse and worse and worse. And now I shudder at the thought of getting poison ivy because it spreads so fast in me and it causes such a painful and itchy response. So you do want to avoid exposure if you can. All right, so now we're coming back to the lymphatic system. Hopefully if we draw out, we'll see. Gosh, we got most of the detail done because there's a lot more over here than there is over here. Lymphatic system is pretty simple. So the first thing, let's just reiterate that the lymphatic system is sort of a second slow circulation. So fluid is constantly leaking out of capillaries, and so it needs to be picked up and returned to the blood circulation. Also, as we've said multiple times, this slower circulation is a great place for white blood cells to kind of hang out and clear debris and pathogens. So it's kind of a home for the immune system. I won't go into this in a great bit of detail, but we're going to come back to this again when we get to the urinary system, and then we'll come back to it again when we get to fluids. So it's a nice little review at this point. So you might want to review this for two reasons. So these pressures, which were called HPC and then OPC, there's going to be very similar pressures when we get to the glomerulus and the kidney. And I don't know if I've mentioned it before, but the urinary system is the most difficult system in AP2. So if you can get this stuff down now, before we get to the urinary system, it's going to make your life easier when we get to the urinary system. The other thing is we're going to do this in a little bit more detail later on when we talk about edema. The main point I'm bringing it up right now, before just trying to prompt you into do a recall, is we pushed fluid out at 10 millimeters of mercury and we drew fluid back in at 8 millimeters of mercury. So it's not really fair to say we lose 20%, but you can clearly see that we lose fluid. So again, it's not fair to say that you lose 20%, but you lose some significant fluid in this process. Someone's got to pick that up. The lymphatic system picks it up. So it consists of vessels and organs. The vessels are things like capillaries, trunks, and ducts, but then there's also organs in here, like there's the spleen, the thymus, the tonsils, the adenoids, and of course, I guess almost missed, the lymph nodes. So that's the lymphatic system. Let's talk about vessels first. So as mentioned before, the lymphatic system is a bit like a second circulation apart from the circulation that carries blood. But the vessels are a little bit different. So lymphatic vessels intertwine, so they're the green ones here that are intertwining around the capillaries, the blood capillaries, which are in red and blue. Lymphatic capillaries differ from blood capillaries in that lymphatic capillaries can kind of have dead ends. Like they don't loop, they just have dead ends going into these capillaries. Also, lymphatic capillaries have to be a lot more permeable than blood capillaries because you have to get fluid into the lymphatic vessels that won't go back into blood capillaries. Lymphatic capillaries, kind of shown down here, they're going to combine into collecting vessels, then trunks, then into ducts that feed the fluid back into the circulation at the right lymphatic duct, which is right here at the right subclavian, and then the thoracic duct. So take a closer look at these lymphatic capillaries. You'll notice these little clefts in here. So they have small mini valves that allow fluid to enter the capillaries, but they're not going to let fluid come back out. So they're kind of like valves in the heart where they'll let fluid go in, but they won't let fluid go back out. So one principle of massage then is to apply pressure to the lymphatic system or to the tissue to push fluid out of the extracellular spaces and into the lymphatic system, where it'll be filtered and it will work its way back up to the blood circulation. So by putting pressure on tissue, fluid will enter lymphatic capillaries but will not escape. In fact, that's one of the ideas behind inflammation, is when you send inflammation into an area because there's been damage, that increased pressure is going to push debris, pathogens, or cancer cells into the lymphatic system. So inflammation also pushes damaged tissue and debris into the lymphatic system. By pushing these things into the lymphatic system, these substances are going to be filtered and observed basically for pathogens in the lymph nodes. We're going to talk about that real quick. So just like veins, pressure from the contraction of nearby skeletal muscle will push fluid into the lymphatic system. Pulsations of nearby arteries will push fluid into the lymphatic system. And in fact, the lymphatic system does have smooth muscle in its wall that'll help fluid flow through the lymphatic system. I mentioned this before, but let's just finish this pass. So fluid enters the capillaries by pressure or inflammation. And once it's in the capillaries, skeletal muscles, pulses from nearby arteries, or smooth muscle in the walls of the lymphatic vessels will move that fluid through the capillaries up through trunks. This fluid's going to work through lymph nodes where it's going to be monitored and where it's going to be filtered, but then the fluid will be dumped back into the blood circulation at the right lymphatic duct or the thoracic duct. Of course, you recall, but we should mention it here, is there are T cells and B cells hanging out in those lymph nodes. And again, T cells. And then recall that as this fluid moves through the lymphatic system and the lymph nodes, there are T cells, I should say T cells from the cell-mediated system and B cells from the antibody-mediated system. Don't forget, too, we've mentioned these as well, I think, or maybe it's coming up, sorry. In addition to the B and T cells, in the lymph nodes, there's reticular fibers, and you would have seen this in AP1 when you did histology. So these are reticular fibers. We would have called them, they would have been more brown in our slides, but look like grapes on a vine. What's happening here is the vine is the filter of the lymph nodes, so as things go through there, that gets caught by this vine or this fishnet. And then the grapes on the vine are macrophages, so macrophages that are going to eat up debris. There's also a particular type of cell in here that's called a dendritic cell, and those, if you recall, are antigen-presenting cells. So those are the ones that are going to activate Th cells. So in addition to the B and T cells, there's reticular cells that create this filtration net. There's dendritic cells, which will act as antigen-presenting cells. So if an infection gets into a lymph node, they're going to activate Th cells. And then there's macrophages to engulf the debris that's been tagged for destruction by complement, as directed by antibodies. So antibodies will tell a complement to kill these things. Those are lymphatic vessels, lymph nodes. So before we get directly into the lymph nodes, we do have lymphatic tissue, and we're going to end on this actually, that's just kind of spread around. That's not necessarily a lymph node. But then lymph nodes, again, just repeating, they have those dendritic cells that are antigen-presenting cells, and they have this network of reticular cells to create a net. So in looking at the lymph node, note there's a lot more vessels, well, maybe not a lot more, but there's more vessels going in than coming out. So this creates sort of trap that slows down the flow of lymph. So if more is coming in and you have fewer escape routes, it kind of slows everything down. There's also crypts and pockets that are full of macrophages and things like that. Again, so that as the fluid goes through here, it slows down and there's time for the dendritic cells and the macrophages and the T, C, and B cells to figure out if there's any bacteria in there. You have clumps of lymph nodes. You have them all over, especially look at this figure. You have lymph nodes all over, but you definitely have clusters in the neck. Those are called cervical. In the armpits, those are called axillary. And in the groin, those are called inguinal. This is why the doctor will often feel those pressure points for inflamed lymph nodes to feel if you have an infection. Summing this up a little bit more specifically, as the fluid goes through the lymph nodes, it's filtered, it's caught by dendritic cells. These dendritic cells are antigen-presenting cells, so the dendritic cell finds a pathogen, it's then going to go back and activate the Th cell. Yeah, a little bit redundant here, sorry. Looking at the structure of the lymph node, there's a cortex, which is the outer covering, there's a medulla, and then there's also an outer covering called the capsule. We're going to see in a moment the tonsils kind of have the same structure, but they lack the capsule. This is an important point that I mentioned before, but now let's graph it all out. So we mentioned before that B lymphocytes, If this is where fluid is coming in out here, B lymphocytes tend to hang out here where the fluid just enters the lymph node. Below that are the TH cells, and they have to be near the B lymphocytes. So the idea is that any pathogens coming through here, if there's only a few, the B cells will catch them, and nothing will make it to the TH cell until you'll end the threats. However, if a lot of bacteria is coming through, the B cells will be overwhelmed, and the T cells, the TH cells, will find antigen-presenting cells that are infected. That means the immune system needs to kick it up a notch. So what that's going to do is the TH cells have to come back to the B lymphocytes, join up, make memory, make plasma cells, and start making antibodies. Well, those antibodies don't do a whole lot unless complement has been brought in to tag those infective pathogens for macrophages. So deeper into the lymph node are macrophages. So what a perfect system. If a few come in, the B lymphocytes will catch it, we're done. If a bunch comes in, the TH cells will find it, will amplify the response. The TH cells will join up with B lymphocytes and make antibodies. Those antibodies will use complement to tag cells for phagocytes, and those phagocytes or macrophages are hanging out a little bit deeper down into the lymph node to basically engulf them at that point. So it's a pretty nice system. To review then, the system is to sensitize the B cell, have TH and B join up, make antibodies, tag cells for the macrophages, and have macrophages clean things up. Pretty nice. I don't know that we need to go through this, but just one last time. Lymph enters via a number of different afferent vessels. It then enters large subscapular sinuses, so it kind of moves around, travels around through these smaller sinuses, slows down, meanders through. It's going to eventually exit via the hilus through efferent vessels, but in the meantime, the fluid has slowed down, so macrophages and T cells and B cells have all had a chance to monitor and carry out their protective functions. That's lymph nodes. Organs. So in addition to lymph nodes, we have some other lymphoid tissues. So we have like the spleen, we have the thymus, and we have the tonsils. So the spleen is kind of like a big lymph node, but it also has some red blood cell function. So it has reticular fibers and macrophages to filter the lymph, but the spleen also filters blood. So the spleen has what are called pulps, and it has two pulps, a white pulp that does the lymph node-like functions, and a red pulp that does things for red blood cells and platelets, so the blood function. So in this figure, you can see the white pulp, and you can see the red pulp. One thing to mention is the spleen has a very dark color because it's very infiltrated with blood. So also note the ribs, the proximity of the ribs to the spleen. So if you get damage to the ribs and it lacerates the spleen, often you'll take the spleen out directly to prevent blood loss. So let's be a little bit more specific about what's happening in the red pulp. So first, the capillaries in the spleen are more rigid than elsewhere. So if a blood cell is kind of stiffening up with age, going through the capillaries in the spleen are going to rupture it. It's not going to be able to squeeze through those capillaries. So this means the spleen is responsible for getting rid of old, rigid red blood cells. The spleen will then take up the products of that red blood cell, so it'll store the iron, and then it'll send the rest of that cell to the digestive system because it's protein, digest it, and turn it back into other proteins. The red pulp of the spleen also makes fetal cells, and it stores platelets. One last quick review about white pulp then. White pulp is an area containing mostly lymphocytes suspended on reticular fibers and involved in immune functions. It's like a lymph node. Red pulp, remaining splenic tissue concerned with disposing of worn out red blood cells and bloodborne pathogens, storing platelets, storing iron. And just one last look again. White pulp, red pulp. The thymus. Not too much to do with the thymus, but from our discussion of T cells, you should remember that while T cells are made in bone marrow, they mature in the thymus. This is also where they go through positive and negative selection to make sure they'll bind pathogens, but will not bind self. So the thymus has two lobes, sits right over the heart. It shrinks with age, and so we won't find it on the cadaver. The thymus shrinks with age. It's virtually non-existent at our ages. I like the way I grouped myself with you youngins. I don't think we need to hit a whole lot here other than the T cells mature in the thymus. Thymus just functions in T cell maturation. It doesn't really do anything. It's not a lymph node. It doesn't fight antigens. Tonsils. Tonsils are essentially lymph nodes in the oral cavity, so they have crypts, they have tuberculi like lymph nodes. They just don't have this outer capsule. So you have 3 sets of tonsils. So you have the tubal tonsils, or they're also called the pharyngeal tonsils, that sit in the eustachian tube, or the tube that connects the inner ear to the oral or nasal cavity. You have the palatine tonsils, which sit down from the hard palate, and you have the lingual tonsils that sit underneath the tongue. Just to show you another view, I often see 4 types of tonsils listed, but I only see 3 tonsils here. And I guess my interpretation of that is that the adenoids and the tubal tonsils are here together in this area. So I don't see them labeled separately. I only see 3 sets of tonsils. I'm sorry, I'm confusing you. I've never figured this out, but there are 4 types often listed, but 3 types shown. So again, these are the adenoids, also called the pharyngeal tonsils, and they're also called the tubal tonsils because they're around the eustachian tube, or the tube that connects the inner ear to the nasal cavity. Palatine tonsils hang down from the soft palates, and then lingual tonsils are below the tongue. Looking here at this figure shows a comparison of a tonsil and a lymph node. And hopefully you see they look kind of the same. They look roughly the same, except the tonsil doesn't have this outer covering that a lymph node has. You can see kind of the same crypts and the same kind of nodules, everything like that. It's probably a pretty good idea to have a lymph node in the back of the throat, because then any pathogen that's coming in through the oral cavity will go into the tonsil, and again, that's where you're going to activate Th cells and say, hey, we better start making antibodies because we got this infection. But it's kind of a bad idea too, because those guys can swell, and here's our airway. These are not even actually that bad. You can see swollen tonsils that really start to look like they're going to cut off the airway. Lastly, our last little thing, we mentioned this before, is this kind of looks like a lymph node, but it doesn't really look like a lymph node. But kind of, these are called Peyer's patches. So you kind of have diffuse lymphoid tissue in areas like the small intestine. This is pretty important because you got a ton of bacteria in here, and we don't want any bacteria starting to worm its way through these walls and get out here. So that's why things like appendicitis are so lethal, because you have a ton of bacteria here, but you don't want any of it out of here. So these patches are really important because we have a lot of bacteria in our guts, but when that bacteria gets out of the intestine, it can really grow and cause larger infections. So Peyer's patches help to make sure bacteria stays in the intestines. That's lymphatic organs. Go through these mastery things. So you can try and find pathologies associated with absence or removal of lymphatic vessels. So lymphedema is a good one. Oftentimes they'll take out lymph nodes when it's providing a path for cancer. So most of us know that this second circulation is great as a second home for the immune system, but it's kind of not good because it's also a pathway for cancer to spread rapidly. So often in someone that has cancer, they'll take out lymph nodes. So think about what that's going to do to fluid balance. You could explore the differences between Hodgkin's and non-Hodgkin's lymphoma, or look up lymph node in Wikipedia. That's a pretty good article. Explore pathologies associated with each lymphatic organ, so spleen, lymph nodes, Peyer patches, tonsils, and thymus. So there's connections between, alcoholism and the inability of the spleen to hold platelets, things like that. So there's some interesting things out there to look up. All right, that's the immune system. Thank you.